Good morning, everyone. Welcome to Grand Rounds on another beautiful sunny morning. Before I introduce our speaker, I'd like to begin with our land acknowledgement as usual, to remind us that Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. And now I would like to introduce our speaker for this morning, Dr. Marie-Ève Robinson. Marie-Ève is an assistant professor of pediatrics at the University of Ottawa and holds a research chair in genetic skeletal disorders. She's a pediatric endocrinologist specialized in metabolic and genetic bone diseases and a clinical investigator at the CHEO Research Institute. Dr. Robinson is the scientific director of the Skeletal Research on Novel Genes with the acronym STRONG, great acronym, by the way, STRONG program, which aims to better characterize the phenotype of rare bone disorders and the quality of life of affected children. She is also the founder and director of the STRONG Clinic, a multidisciplinary clinic for children with genetic bone disorders. Relevant to our talk today, Dr. Robinson is currently involved in publishing practice recommendations on the diagnosis and management of metabolic bone disease of prematurity. She is also involved in national and international efforts to advance knowledge and collaboration on pediatric bone diseases. She chairs a bone and mineral special interest group with the Pediatric Endocrine Society and serves on the steering committee of the Canadian Consortium on Children's Bone Health. So Marie-Ève is perfectly situated to speak to us today, and the title for her presentation is Handle Me with Care, an Approach to Perinatal Bone Disorders. Handing it over to you, Marie-Ève. Thank you very much for presenting.
Thank you, Mona. Thanks for the kind introduction. Great to see so many of you on this beautiful day. So I'm just going to share my screen. All right. Here you go, Mona. Do you want to give me a thumbs up? Awesome. Thank you. Good. So today I'm going to talk about an approach to perinatal bone disorders. And I was just kind of browsing on who's online. I see a lot of neonatologists, geneticists. So that's really wonderful, and endocrinologists as well. Just starting off with my disclosure, so I have a few study grants and consulting fees with some pharma companies. So today there's three main objectives I was hoping to achieve. So first, I want to talk about the key components of perinatal bone metabolism. And that's really because that will serve as the kind of building bones or building blocks to basically know how to diagnose those disorders and how to treat them if we really understand the drivers for perinatal bone health. Then I want to talk about the diagnosis and management of both common skeletal disorder that you will encounter neonatally, but also life-threatening bone disorders, because those are really the ones that hopefully we will not miss, and that can actually be treated in some instances. And I'm going to then briefly discuss about how to differentiate bone disorders caused by nutritional deficiencies versus mechanic causes versus genetic causes. So just one slide about why should pediatricians or pediatric subspecialists care about bone health, because sometimes we think about bone health as this kind of really niche area. And I think it's really important because as pediatricians, we want to give the kids the best start in life. And this is only possible through a strong skeleton. So infants with weak skeleton can have a lifelong chronic pain. You might see them in clinics later on with fragility fracture. They can also die of respiratory failure because of small chest size. So a lot of different ways that those children can present. And unfortunately, it's actually quite common for some of those infants with bone disorders to actually go misdiagnosed, to not get to the right specialist, and end up not having access to treatment they need. And sometimes that can actually be a life or death treatment. So hopefully today we'll be able to identify both those common and those life-threatening bone disorders so that those neonates can get the care that they need. A few pictures here of patients. So on the left side, that's a little boy born with severe osteogenesis imperfecta. The little girl in pink is a girl with hypophosphatasia, so we'll talk about that a little bit. And in the middle is a boy with rickets of prematurity, so that's probably the type of disease you'll see the most commonly in premature infants. So jumping on to talking about those key components of perinatal bone metabolism. So I have one slide that's a little bit talking about bone cells so that we're all having the same language and same definition. So this work was done by Frank Crouch and Dr. Glover, published in Lancet a long time ago. So basically, I'm showing here a bone. So on the left side, you have a long bone, and I'm zooming on the cortical bone, which is the outer shell of the bone. And when you look at this cortical bone, there's kind of three cells that are really important in bone. One is the osteoblasts. So those are shown here in pink. So those are the cells that lay out new bone. So they lay out what's called unmineralized bone, or osteoid. And that's a soft bone that then gets mineralized. And here is shown in blue. And this bone is hard, so it's full of calcium and phosphate. And then you have those cells called the osteoclasts that are actually resorbing bone. And in the setting of bone remodeling, you have somewhat of an equal balance between the osteoclast activity and the osteoblast activity. So when we talk about the key component of perinatal bone metabolism, it all comes down to the predictors of bone mass. And when we think about bone mass, so basically the amount of calcium in bone and the amount of bone you have, bone mass is directly related to bone strength. So, and that's what we care about as clinicians, because if you have weak bones, that's when you can have fractures. And there's four key things in perinatal bone, but also in children of any age, that determine this bone mass and therefore your strength. So one is an obvious one is nutrition. So calcium and phosphorus, as well as vitamin D. And that's really important to have a strong bone mass. And that's especially important for infants because up to 80% of the fetal mineral accrual actually occurs in the third trimester, with a peak around 32 to 36 week gestation. So that means that any infant born prematurely, they don't have the chance to go and have this fetal mineral accrual from the mom, and therefore they're at high risk of having low bone mass and fractures. The other key things is hormones. So as endocrinologists, obviously that's something we care deeply about, as well as enzymes. And those are tightly related to your nutrition because hormones, especially for example, parathyroid hormone, has a main mechanism of action that is purpose is mainly to maintain normal calcium in the blood. And by doing so, it can also increase bone resorption, which can ultimately lead to problem in bone mass. There's also an enzyme called alkaline phosphatase that's in charge of mineralizing the bone, and that can sometimes be mutated through gene mutations. The other big component are genes. So when we think about genes that are hard driver of bone, we think about the type 1 collagen gene, that's the COL1A1 or COL1A2. And that can, if you have mutation in those genes, you can have a structural anomaly in your collagen protein such that the structure of the bone is weak or is abnormal, and therefore you have a lower bone mass and a risk of fracture. And you can also have mutation that actually will impact, as I said before, the alkaline phosphatase or the FGF23, which are basically also determinants of mineralization. And the last piece, which is potentially what we see more commonly in clinic, is the mechanics. So for bones to be strong, there needs to be a load on the bone. So healthy muscle, a baby that's moving or a child that's moving. So when the bones are not stimulated well, and that's called the mechanostat theory, you can have a weaker bone strength or have altered bone mass. So the prime example of this in an infant would be someone that has oligohydramnios. So in utero, they're not moving well. And because of that, you can have issues with your bone mass. Another example is a spinal muscular atrophy, where you have atrophy of the muscle, and as a secondary effect, you'll have osteoporosis. And when we think about those key drivers, there's one big umbrella term that we call metabolic bone disease that basically encompasses all of those disorders. And ultimately, if you were to do a DEXA scan or look at the bone mineral density of children with any of those disorders, they would all have a low bone mineral density. So we're not able to differentiate with just a DEXA which component is affected. There's two big categories of disorders that are stemming out of those metabolic bone disease, and it's really important to differentiate them because the way we recognize them and treat them is completely different. So on the one side in orange, you have the mineralization defect. So that means that you have an issue with the amount of minerals on your bone. So that could be calcium or phosphorus, or you can have a problem with alkaline phosphatase where you're not able to mineralize your bone. And typically in those disorders, those children have enough bone structure, they're just poorly mineralized. And that's completely different from osteoporosis, which basically, typically those children have normally mineralized bone, but they have either an abnormal structure of the bone or there's less bone, and therefore they're also at risk of fractures. And in that category of osteoporosis, there's either primary or secondary. So when you think about primary osteoporosis, that usually means there's an intrinsic bone problem. So often that's from genetic mutation, like in the case of osteogenesis imperfecta. And in secondary osteoporosis, you can have it, in this example, issues with mobility, for example. So you have an extrinsic problem that then gives you weaker bones. So just a slide here to kind of really drive home the point that those disorders are so different. So this is a bone biopsy in the middle. So that's basically, we take a little piece of bone right below the iliac crest, and we send that to Montreal at Shriners, where it gets analyzed. And you see here on what's shown in green is the mineralized bone. So you have two cortices that are mineralized. And in between the cortices, you have those little bone islands that are trabeculae. So that forms a trabecular bone. And in between, you have the bone marrow. So in the setting of osteoporosis, what happens is that you have basically normal mineralized bones. So you see how this blue bone is well mineralized, but there's less bone. So here there's a less trabecular bone. So that's osteoporosis. And that's very different from rickets, which is shown here, where you see you're not lacking bone in itself, but you have more unmineralized bone, which here is shown in pink. And that will therefore make your bones weaker because there's a lack of calcium and phosphate on the bone. And both can lead to low trauma fracture and kind of presenting similar with clinically. So now that we have talked about those key components of perinatal bone metabolism, I want to zoom on specific disorders that we encounter both commonly or the ones that are life-threatening and that we should therefore not miss. So the type of bone disorder that typically present in the neonatal age, when I think about common bone disorder, it's typically around prematurity. So that could be either rickets of prematurity or osteoporosis of prematurity. And life-threatening bone disorder, I'm going to mainly talk about hypophosphatasia and severe inherited bone fragility disorder. The classic example would be osteogenesis imperfecta. So if we zoom here on rickets of prematurity. So going back to that little algorithm I showed you, here we're really talking about a nutritional disorder. So it's actually not a bone disorder per se. They're lacking calcium and phosphorus because they're bone premature and they were not able to accrue bone in utero. So I have a classic example here of a case that was seen here. So a 23-weeker, complicated past medical history, including chronic lung disease, diuretic use, and undergoes his first screen, because we do have a protocol here at CHEO that basically warrants investigation to be done when infants are born premature to make sure we're not missing rickets of prematurity. So this little baby had a high alkaline phosphatase, which is usually a marker of metabolic bone disease, has a low phosphorus and a normal ionized calcium. And as per our protocol, typically when there's an abnormal screen that's done at 4 weeks of life, we then go on to do a second set of investigation to try to determine what's driving the anomalies. And typically that includes a vitamin D level, a 25 hydroxy vitamin D in parathyroid hormone to try to find out what the cause of the low phosphate or the low calcium. So this little baby on second tier investigation had a 25 hydroxy vitamin D of 48, which is considered low, but in the setting of bone disease, we actually use 30 as a cutoff to really try to see if this can be associated with a mineralization defect. Had a normal parathyroid hormone and had a high transfibrillary reabsorption of phosphate of 98%. So what does that mean? So typically when infants have a nutritional disorder, their kidneys will do all they can to reabsorb all the phosphate they have. And therefore, their reabsorption of phosphate will be extremely high. So this is typically a normal compensatory mechanism that we see in those infants. And an X-ray was done that showed clear cupping and fraying of the metastasis. So that's a wrist X-ray that you see, and you see clear cupping and fraying of the growth plate. And rickets is really a radiographic diagnosis. So we can only diagnose rickets with an X-ray. which is why we always want to do wrist or knee x-ray in infants that actually screen positive, and that's part of the algorithm. So what does this patient have? What's the diagnosis? So the diagnosis for this patient is rickets of prematurity, right? So mineralization disorder. And here I'm showing you the 3 types of disease that an infant can have related to prematurity, and they're very, very different, but often the terms are kind of used interchangeably, and they can be hard to differentiate. So when we talk about rickets, we're really talking about a nutritional disorder. And that's the one disorder we actually want to screen for in infancy, because screening can prevent a fracture, because we can optimize calcium and phosphate early on. And that will lead to prevention of limb deformities, dental anomalies, even hypocalcemic seizures. And that's why we have this algorithm here at CHEO, which the neonatologists are very used to using. And that's very different from osteopenia of prematurity or osteoporosis of prematurity, where those infants can have reduction in bone mass, but have completely normal phosphate and calcium. And the difference between the two is that in osteoporosis of prematurity, that's typically when the infant would have undergone a fracture. And that's when obviously bone health wants to be involved. And I'll talk a little bit more about osteoporosis of prematurity in a little while. So what are the population that are at risk of rickets of prematurity? So this is just under revision, but that's part of this practice recommendation that we're publishing. So infants that are born less than 28 weeks are at risk, and that's because of this lack of in utero mineralization. Infants that are less than 1.5 kilo, and that's because a reduced placental transfer of mineral in utero can happen with low birth weight. Total parental nutrition, and that's true for infants, but also for children later on. And that's because TPN typically provide at best around 60 to 70% of the mineral requirements of an infant, and that's due to solubility constraints. So it's very common for those infants to not be able to have what they need from a calcium and phosphate perspective. Chronic lung disease is another one, and that's because of the high energy requirements and often the fluid restriction that comes with the management of that. Long-term diuretic use through the effect of hypocalciuria from diuretics. Neck, because of poor gut function, prolonged parental nutrition, so again, they're not able to have enough calcium and phosphorus, and fluid restriction for the same reason. So the mechanism by which rickets of prematurity can occur, there's 3 different mechanisms. So one, you can lack calcium intake alone, you can lack dietary phosphate intake alone, or you can lack vitamin D, which is very important for absorption of calcium and therefore can lead to low calcium and phosphate, or you can have any combination. And one thing I really want to drive home, and that's a slide courtesy from Leanne Ward, is that rickets can only occur in the setting of low phosphate. And that's because, and as I'm showing here, you have a bone, so that's a normal bone that's shown, so that's a histology slide. In blue, you see the chondrocyte, so that's the growth plate. And in pink, you have the mineralized bone. And if you were to do an x-ray of this, you would basically see a gap here at the level of the growth plate, because that's not visible in x-ray. And when you have poor or low phosphate, what happens is that the chondrocytes, they're no longer able to undergo apoptosis, and they become hypertrophied. And this is actually what you see on x-ray, is the effect of the hyperplasia of this hypertrophic zone of the growth plate, where you're going to see irregularity, lucency, cupping, and this is only possible through a low phosphate. It is not possible through a low calcium, for example. Now, what might say, well, you just said that you could have rickets of prematurity from a poor calcium intake. So why is that? So calcium deficiency itself can lead to rickets via parathyroid hormone. And that's because parathyroid hormone, which typically increase in the setting of low plasma calcium, also has the effect of increasing phosphate excretion at the kidney. So it's a phosphaturic hormone, and therefore there will be less phosphate at the level of the at the level of blood, and that will be resulting in rickets. And that's really why a dietary calcium a dietary deficiency in calcium could lead to rickets. So this is basically just showing the algorithm that are part of those guidelines. But really what I want to drive home is that We screen those infants at 4 weeks with calcium and ionized calcium phosphorus and alkaline phosphatase. And what's important is that we use level of parathyroid hormone, in some instance, transtubular reabsorption of phosphate, to determine if the infant primarily has a calcium deficiency or a phosphorus deficiency, because you will slightly change the amount of calcium or phosphorus you give back based on that. But what's really important is that regardless of this deficiency, you never want to give unopposed phosphate. And that's because phosphate drives PTH. And if you give that for too long without giving calcium, you might end up with hyperparathyroidism. And that might be a problem. And so whenever phosphate is given, and that's true not only for infancy, you always want to maintain an adequate calcium to phosphate ratio that has some calcium in there to bring down that PTH. And as part of this algorithm, really what we're saying is that you want to supplement with either calcium and phosphate and keep checking your serum blood work every 2 weeks or so until the blood work has normalized. And ultimately, this is a transient disorder. And you also want to do your X-ray to look at rickets as well as resolution of rickets. So just to close the loop on that first case that I was presenting to you, so this little infant was started on high dose phosphate supplements alone, and he developed hyperparathyroidism, right, where PTH rose dramatically. And that actually resolved when the extra calcium was added. So really, really important to maintain that nice calcium to phosphate ratio. So one quick word on osteoporosis of prematurity, right, which is a kind of different disease that usually stems from mechanical problems. So because those infants are immobile in NICU, or because they're on steroid therapy, for example, or because of other chronic disease, they can actually develop osteoporosis in the setting of normal mineralization. So osteoporosis is actually a transient disorder. Typically, neonates recover without bone-specific intervention. We rarely treat osteoporosis of prematurity because of the transient nature of it. But despite this, we still want to be consulted if there is a fracture. And the management is really all around fracture prevention. So that means alerting members of the medical team around safe handling. We want to often display a sign at the bedside to signal bone fragility. We can do therapeutic positioning of the neonates to promote muscle strength. And there's also some physical therapy program that can be done, again, to really increase muscle mass, which will therefore also improve bone strength. So now moving on to those life-threatening bone disorders, because those are really the ones that we do not want to miss, that are kind of rare, they're very rare, and that actually we have some therapies to help those babies. So I'm going to first talk about hypophosphatasia, which is a very rare condition that happens when you have a mutation, so it's a genetic problem, in the gene that's coding for alkaline phosphatase. And as you might recall, alkaline phosphatase is important to mineralize the bone, so this is actually a mineralization defect that's caused by genetic mutation. So this is a case here that occurred at CHEO when I arrived a few years ago. So this is a mom that actually had a history of having to terminate pregnancy because of an affected child. And at 20 weeks, she did her ultrasound, and her ultrasound showed very small long bones. And she had a femoral length to foot ratio of 0.2, which means that the femur is actually shorter than the foot. And usually a femur in ultrasound should be around at least as long as the foot. So that tells you that the bones are very, very short. There was some abnormal posturing, and this baby had a very small chest. So this baby was born at 39 weeks, had ABGARs of 1, 1, and 1, and actually died of respiratory failure, and was found to have recessive pathogenic variants in that ALPL gene, so the gene coding for alkaline phosphatase. So hypophosphatasia has a really wide range of phenotypic presentation depending on the function of this alkaline phosphatase enzyme. So typically when children have recessive condition, they can have a perinatal form, which is the form I just presented, very, very severe. When you have poor mineralization, they can also have an infantile presentation where they have some function of the alkaline phosphatase, but really poor. And if you have a dominant disease, you can also have a very mild phenotype, all the way to what's called Hypophosphatasia, which is basically restricted to a dental phenotype. And there's one, just to make things more complicated, there's one form that's called a benign prenatal form. And that can be very hard to distinguish from the severe perinatal form. And the benign prenatal form actually, basically, I'll show you a slide later on, but those children can look like a perinatal form. And then when they're born, they actually have a very, very mild phenotype. So the reason why I'm talking about hypophosphatasia today is that there's a new drug, it's called asfotase alfa. It's an enzyme replacement therapy. And it's a Canadian success story, actually, because it was developed in Montreal by Philippe Crane in 2006. In 2006, and there was a number of trials using asfotase alpha in infants with hypophosphatasia, and the drug has been approved by Health Canada in 2015. And there's multiple trials that are continuing since that time. And asfotase alpha, we need to be aware of it because that can be something that can be offered to those infants. And that little patient I showed you, unfortunately, was not offered this option. And I think that's important for parents to at least be aware that this is a potential therapy. And I'll show you some data on it. Just talking about who's a candidate for this drug. So asfotase alpha is approved in Canada for any patients that have a pediatric onset form of hypophosphatasia. Here's a little slide I'll before I jump back on asfotase alpha, just to show you that benign prenatal form. So this is an ultrasound of a child that had at 24 weeks finding a really bowed femur, and had actually a history of an aborted fetus. So his sibling was aborted around the age of 20 weeks, and that's the aborted fetus here that you can see, really poorly mineralized skeleton. But this same boy was carried through to full term, and actually without asfotase alpha, went on to have almost a normal life, and you could see him there standing. And that's a form, that's the benign prenatal form, and that's a form that when you see that in ultrasound prenatally, it's very, very hard to differentiate from an aggressive perinatal form. And that's why we have to be really, really careful when we predict lethality using ultrasound, especially in the second trimester for hypophosphatasia. That's a slide showing the effect of asfotase alpha, so really impressive effect. So you see on the left, you have a little boy, a little infant with perinatal hypophosphatasia, and you can see that the skeleton is not mineralized, right? You cannot even see the ribs, you don't see the vertebrae, you don't see the femur. And with asfotase alpha, now you have mineralization of the skeleton. Similar image here of a baseline hand x-ray where you don't have any mineralization of the digit. And with 24 weeks of asfotase alpha, you have mineralization. And of course, those babies still have other issues, right? It doesn't completely rescue the phenotype, but it's for sure increased survival and has pretty dramatic results. So that's why it's important to refer any cases of suspected hypophosphatasia to endocrinology and bone health. And I think that should be done prenatally, right? So we can start that conversation with the family early on, as opposed to when the baby's already born. So moving on to severe inherited bone fragility disorders. Talking about most, when we think about severe inherited bone fragility disorder, we typically think about OI. So OI is basically a genetic bone condition where you have fragility of the bones. And when you think about classic OI, typically those children have loose sclerae, they can have dentinogenous imperfecta, hyperlaxity of the ligaments, fractures, scoliosis, short stature. And there's 4 different types when we think about classification, when we think about classic OI. So type 1 is the lethal form, and that's really a type that you can only diagnose after a child has passed away. And the type 3 is the most severe type in children that are actually surviving. So those children typically are wheelchair bound, have quite short stature, have a number of fractures. Type 4 is kind of in between type 3 and type 1, so it's the moderate type. And type 1 OI is the mild form, and sometimes actually we diagnose parents with type 1 OI because we're seeing the child in the clinic, just to kind of show you how it can be quite mild sometimes. This is a slide here showing there's a number of genes that are causing bone fragility. And when the field started, we were kind of mostly thinking about col 1A1 and col 1A2, but that's really, really expanding now. And the way that we call the varied disease kind of depends on where you look at. So if you look at OMIM, typically they'll call it OI and they'll give a number to OI. There's OI 17, OI 18. And if you look at the scale of dysplasia nomenclature group, they'll have different names. And that's just to show that the terminology is just inconsistent. And we are really trying to move towards basically naming the severity of the condition. So saying mild bone fragility, moderate bone fragility, or severe bone fragility, and simply state the genes that's affected, rather than finding a different name or a different type of OI. So here I want to show, talking about OI, so that's a case that occurred about 2 years ago here at CHEO. So this woman was 20 weeks pregnant. That's the result of her 20-week ultrasound. And you could see that the chest of this baby was actually normal in dimension, but the femurs and tibias were quite bowed. So you see here tibia with quite significant bowing, and the femoral length to foot ratio was low. So again, the femur was shorter than the foot. This woman went on to have ultrasound after 25 weeks, and the bowing had progressed. So very significant bowing of tibias and femurs. So this mom was actually told that her girl had a lethal scale dysplasia, and mom actually donated her clothing to Rogers Nielsen House. And this baby, so that's the baby when at 1 day of life after birth. So that's her chest X-ray. So quite thin ribs. There's some rib fractures, very deformed femur, tibia. There's actually already a fracture there, and multiple previous fractures. And baby was actually intubated at 1 day of life because she actually had a cardiac arrest needing chest compression and intubation. That's her skull X-ray, so very thin skull, plagiocephaly. She was actually able to be extubated at 1 week of life, and we started bisphosphonate therapy at 3 days of life in this girl. So I want to use this example to really kind of walk you through the investigation that are done for children with low trauma fractures, some of which should be started often by the pediatric team or neonatology team, and sometimes started by endocrinology right away. And this is adapted from a really good paper by Leanne Ward in JCEM in 2020, talking about this approach. So this is just kind of an adaptation. So when patients present with clinically significant fractures, and that can typically be what we call low fragility fractures. So you have a fracture because of an event that is not typically sufficient to break a bone. So when it happens, the first thing we do is we rule out amenalization disorders, and that again can be done by the pediatric team, because this is very easy to treat, right? Rickets is easy to treat and should not be missed. So typically those children should have X-ray of the knees and wrists, right, to look at that row plate to see if there's rickets. And they should have investigation including calcium, phosphorus, alkaline phosphatase, parathyroid hormone, and vitamin D. Once this is ruled out, the second step is to rule out an undiagnosed acute or chronic illness. And that's through a thorough physical examination, history, screening blood work as relevant, looking at the medication, seeing if the child's on steroids. And then once this is done, then we do our formal osteoporosis evaluation. And that's also when the patient should be referred to bone health. So that would be typically a spine X-ray to look at vertebral fracture, a DEXA scan, and sometimes we do other X-rays as well. And once we've diagnosed osteoporosis and we've ruled out an acute or chronic illness, we want to assess for evidence to support a diagnosis of inherited bone fragility or a genetic cause. And that's when we're going to do and order an X-ray, for example, of the skull to look at worm in bones, a skeletal survey, and genetic testing. So if we go back to that girl, where obviously her diagnosis was more evident, but we still do all those investigations. So we have ruled out rickets to a normal bone biochemistry panel. And we did our formal osteoporosis workup, which showed that her lateral spine was actually very normal. She did not have any vertebral fracture. As you can see, there's no loss of height in the vertebrae. We did a DEXA scan, that's on the right upper panel. And she actually had a normal bone mineral density. And that's quite common in infants with osteogenesis imperfecta. We started her on bisphosphonates, and that was even before knowing her genetic mutation. She later was found to have a genetic mutation in COL1A2. And because of her phenotype, again, not because of the mutation itself, we diagnosed her with osteogenesis imperfecta type 3, which is the most severe form of OI. This is her leg length, so an X-ray of her left leg at 4 months, so you can see already the difference in the bones. And this is her a few months ago, kind of doing really great cruising here. So she is wheelchair bound. She had a number of surgery, but she's really living a good life, and we're seeing her every 3 months in the clinic and treating her with zoledronate. So I'm presenting this case really to make the point that it can be really tricky to diagnose or to predict lethality on an ultrasound. And in the case of OI and hypophosphatasia, we should try to nuance that conversation. And that's really hard because some skeletal dysplasias are clearly lethal. And certain markers on ultrasound can be used to assess or predict lethality. And it's important to set accurate expectation with parents, right? So there is a role to kind of be able to predict lethality in a way, but it's very, very difficult to do. And the geneticists and the maternal fetal medicine expert have a really challenging job when it comes to that. And I think in those cases, the conversation around lethality needs to be nuanced. And perhaps this would be a good time to really involve that multi-D team early on and have those conversations to really be able to have a better sense and really give all the possible information to the families. This is a different case, so that's my last case. Again, a mom that presented with ultrasound at 20 weeks, showing very short long bones, bowing of the long bone. You can see on the 3D, you have really significant bowing of the tibia and femur. She had a small chest size, and you can see here the femur is actually much shorter than the foot. So again, really, really short long bones. Those are the radiographs of this same infant at birth. So here's her chest radiograph on the left upper panel at 9 days. And you can see very small chest, beaded ribs, so that signals that there was a number of fractures in the ribs. You can see her spine, so it's a lateral spine X-ray on the left upper panel here, where you can see there's significant platyspondylar vertebral fracture. So her vertebrae are completely collapsed with loss of vertebral height. Her skull X-ray here shows that the skull is extremely thin. There's significant plagiocephaly already at 1 day of life. And at the bottom of the screen, you can see her left arm X-ray showing very deformed bone, very gracile, lots of previous fractures, and same thing in the femurs. So this little girl we treated with bisphosphonates at 7 days of life, and that was really to help her with pain, because infants with OI with so many fractures are in severe pain, and bisphosphonates are a potent bone analgesic, and therefore we do want to start bisphosphonates as early as possible, even in cases where perhaps the family do not want to, or only want to have supportive care. So this baby passed away at 16 days of life on CPAP. And because she passed away, that's when we made the diagnosis of OI type 2. But again, this diagnosis can only be made when we observe that the child could not survive. And that's just to contrast the other case where she actually survived and had a diagnosis of OI type 3. So just moving on to treatment a little bit, just the bisphosphonates are our beloved drug as endocrinologists specialized in bone health. And they work really, really well, and we use them very commonly in the bone clinic. So bisphosphonates, just in a nutshell, what they do is that they're analogs of inorganic pyrophosphate, and they attach to mineralized bone. And when they attach to mineralized bone, the osteoclasts, right, those cells that resorb the bone, they go and resorb, and actually they take on some of that bisphosphonate that is attached to the mineralized bone, and they become intoxicated, if you will, and no longer able to do their job. So the osteoclasts become inactive. So in the setting of a normal bone, like you see in that right upper panel, you see that you have this equilibrium between the osteoclast and the osteoblast. So you always have some bone that's newly formed, some bone that's resorbed. But when you add bisphosphonates and you intoxicate the osteoclast, then you end up with more bone that is not resorbed, and therefore you have thicker, in this instance, thicker cortices because of bisphosphonates. So bisphosphonates are kind of the medical therapy for treatment of severe OI, but I just want to point out here the kind of overall therapy. So prenatally, the services that should be involved obviously are maternal fetal medicine and genetics, but also endocrinology early on, including prenatally, so that we can have a conversation with the families, and we can also advise, around quality of life and around what we observe later on. Postnatally, those infants can typically be breastfed, but they can also have respiratory compromise because of small chest size, as I showed you, or weak sucking reflex that are quite common. We want to supplement with vitamin D, and we do want to treat with intravenous bisphosphonates as soon as renal function is established. So that could be as soon as 3 days of life, and that's why it's really important to involve us early on. And safe handling is really important. I have a slide on that, and that is relevant not only for infants, but also for any patient that's admitted on the general pediatric floor with bone fragility. We had a case recently of a girl with CP, with cerebral palsy, that had a fracture in hospital with manipulation. So really important. So those, particularly for infants, typically we want to suggest frequent repositioning. They could use, sometimes we can use gel pad to put under the skull to prevent, or at least try to slow down the plagioccephaly. We want to use roll blankets or soft foam edges to support the side of the baby, and that's because if we put the limb back closer to the midline, it's easy for baby to move and not have to fight gravity, and that's very good for muscle as well. Movement should be slow, gentle. We don't want to pick up the baby under the axilla or rib cage, and we always want to support both the head and the buttocks at the midline. And typically, we like to have some sign at the bedside that actually have the instruction around handling, so that people are aware before they go and handle the babies. The OI Foundation have a really neat handout for parents. I put the website on the right lower corner of the screen. And as I mentioned, so OI is really a multi-D treatment, right? So we have physiotherapy, occupational therapists that are very important for rehab after fracture, but also for mobility, pediatric endocrinologists to treat the bone fragility, orthopedic surgeons, right? Because especially the severe OI, they often need intramedullary nail rodding to correct the deformities, and as well as to correct the scoliosis. One slide about what's coming up in terms of emerging therapeutic targets, because the bone disease field is rapidly moving right now, which is quite exciting. So obviously there's the bisphosphonates, which, as I explained, actually are anti-resorptive agents, so they actually intoxicate the osteoclast. There's 2 new kids around the block that are both antibody therapy. One is an antibody against TGF-beta signaling, and that ultimately results in increased bone formation when this antibody is given. And there's another one called anti-sclerostin, which is an antibody against sclerostin, which ultimately lead to also increased bone formation and decreased bone resorption. I won't go into the detail of the specific pathways, but there's some clinical trial coming up for both of those agents, which is very, very exciting, and just showing how the field is moving quite rapidly. Really quickly, just to discuss one last slide about how to differentiate the bone disorders based on if they're nutritionally based, mechanical based, or genetic, clinically, right? Because I've talked about the pathophysiology and different components of perinatal bone health, but how can we make a difference clinically, which is quite important. And that's, I'm on my last few slides now. So this is just a slide to show you that we really have to act early, because a genetic problem actually obviously are carried on all of your life. So this is a little graph that we published a few years ago. So on this y-axis, you have the total bone mineral content, and on the x-axis, you have the age. And if you take a healthy female, which is shown here in the solid black line, you see that there's bone mineral accrual that occurs during childhood, and you attain peak bone mass in early adulthood. And after that, you go into a phase of bone maintenance, where you remodel your bone, but the amount of bone you form is the same as the amount of bone you resorb. And then you go on to a phase where you actually lose bone, which most of us on this call are in that kind of downward phase. But when you have a child with a genetic defect, what happens is that this bone accrual is less, and therefore the achievement of peak bone mass is less, and therefore this deficit is kept throughout life. And that's why as pediatricians, we really have a big role to play, because this growth is a critical phase at which we can intervene. So I like to target that last objective of talking about how to differentiate those big categories of bone disorders. So clinically, it's quite easy to differentiate the cause of the bone problem. So in a setting of nutritional cause, most of the time you'll have a low phosphorus and or a low calcium in the blood work. And that can be accompanied by a low vitamin D and a high PTH as a result of this low calcium. When we're talking about a mechanical or environmental causes, clinically, that also is usually quite obvious. You'll have chronic steroid therapy, for example, a patient with an underlying condition like SMA or underlying muscle deficit. The genetic piece can sometimes be a little bit harder to differentiate, especially when the genetic piece leads to a mineralization defect. So often those patients, I didn't touch it around those disease, but basically you can present with low ionized calcium and phosphorus, but they're not responding to your standard supplementation. So that's a time where you should think, okay, there might be a genetic problem. Another instance is low serum alkaline phosphatase, like in the setting of hypophosphatasia. And finally, if you have fractures in the presence of normal serum biochemistry and you don't have secondary causes, that's when we should really think about the genetic cause. So what are the pearls that I'm hoping that we'll remember today? So first is around lethality and how hard and challenging it is to predict lethality on prenatal ultrasound, and how involving a team of genetics, bone health, MFM, NICU, palliative care is very important very, very early on. Rickets of prematurity is a nutritional disorder. Treatment is restricted to calcium and phosphorus intake. It's not a bone disorder per se, it's transient. And there's a number of new therapies that have emerged in the rare bone disease field, some of which are life-saving, like asfotase alfa. And so we really have a due diligence and not miss cases of hypophosphatasia. And finally, that severe perinatal bone disorders should be managed through the involvement of a multi-D team as early as possible. Just one quick slide on the STRONG clinic, which is the clinic where we see children with genetic bone disorder that are complex. So the complex form of skeletal dysplasia and the kid that actually need that multi-D care. So in that team, we have Sonia, who's the program manager on the research side, because that STRONG clinic is tightly linked to a research program. We also have Dr. Laser, who's our geneticist. We have 4 great radiologists that actually are with us in clinic and helping to interpret those skeletal surveys, especially useful in the case of undiagnosed skeletal dysplasia. We have orthopedic surgeons, so that's Dr. Sasha Carson and Kevin Smith. We have Dr. Ward as well, who's sitting in the clinic and who's also acting as a collaborator. And we have Dr. Rausch, Kim Boycott, also acting as collaborator on the research side, and Mahika, who's the nurse in the bone clinic, but also participated in the STRONG clinic. And as I said, this program is slightly linked to the research program, and the aim of the STRONG research program is to really bring a forum for novel skeletal gene discovery, in-depth skeletal and muscle phenotyping of rare bone disease, and we also focus on patient-reported outcomes. So if you have any patients that you feel need that multi-D care, feel free to contact me so that they can be seen in this clinic. So this is my last slide, just coming back to those cases I presented initially. So I'm just showing here that the boy with the H on the shirt. So that's a little boy that had rickets of prematurity that's doing quite well now. On the right upper panel, that's a boy with severe OI that's doing well. Now the boy on the left lower panel, the little baby did not survive. He had OI type 2. And then the little girl on the right lower panel, that's actually not my patient, that's Cheryl Grinsberg patient. She's actually a girl that had hypophosphatasia, treated with asfotase alfa, and she's now having fun in the little car. So I want to thank you to all my collaborators, especially Leanne Ward, Sonia Dover, Joanna Laser, Sasha Carson, Kevin Smith, Kim Borka, and Marika Pagé. So happy to take any questions. I hope that was helpful to you. That's my last slide that I found really funny.
Nice cartoon to end with. Thank you very much, Maria. That was a really great presentation. I think I really appreciated how you started taking us through it very easily and comfortably with a conceptual approach of skeletal disorders as they affect premature infants. You gave us some really great cases to illustrate the different types of disorders. You talked about the current and new treatments. And then you summarized really well what the take-home points that we want to remember, that we need to remember. And I think your slide at the end really demonstrated how this is truly a multidisciplinary approach to this patient population. So really wonderful presentation. And you've left us with some time for questions. So thank you for that too. So I'm going to suggest we take down the slides and then open it up for comments or questions from anybody. You can either put your hand up or just turn on your camera and your mic and start talking. Clearly wowed us, Maria. Here we go. Tom Kavesi with the first question. Go ahead, Tom.
Good morning. So Mary, thanks for a wonderful talk. It's rare that I attend an endocrinology talk I understand. So I think that speaks well to what a clear presentation you gave. I just want to say I've had two patients, one with hypophosphatasia, that may be the case that you presented, who passed away before a year of age and before their treatments available, and just devastating. And I think it really speaks to how severe these diseases are. And when I first came to CHEO, I had a patient with OI type 3 who was certainly wheelchair enabled, very, very disabled by her fractures, went on bisphosphonates when they first became available and improved somewhat with that. Passed away when she was 17 or 18, I think, intraoperatively. She had some surgery, I think, in another center and passed away. But these are devastating diseases, and it's important that we're really aware of them.
Yeah, thanks for bringing those cases, Tom. And it's actually interesting to see how the field has changed, right? Especially when it relates to your first case. Yeah, thanks for sharing that. The very, devastating conditions.
Thank you, Tom. Just a question from me, Maria. How often would you be involved with patients who, patients who were stillborn or died without your involvement previously, who had an identified or potential bone disorder for, in terms of future pregnancies?
Yeah, it's a good question. So we get involved often when mom is pregnant with the second child, and there was the history, right, of miscarriage or that mutation that was found, and then we can counsel around that. So we get involved there, and sometimes we actually get involved when genetics sees those patients prenatally, and they're not sure what type of facial dysplasia they want to kind of chat, or sometimes MFM also. So we are involved as well prenatally sometimes, and that's very, very helpful, especially when we can meet the family. So yeah, and I think there's room for us to be more involved as as those disorders are more and more well known, right? As we have more and more genes, and we can, especially in case of family history, right? When there was that history of genetic mutation. So yeah, great question, Anna. Thank you.
Wow. Great, thank you. And there is a question in the chat. Interesting question. How do you safely carry out CPR in these babies?
Oh gosh, yeah. I mean, ABC, right? So it's the same thing, right? You do CPR in the same way, but often they will have rib fractures after that. That was the case of that little girl. Sometimes airway can be difficult, right? Achieving air, like they can be hard to intubate. Sometimes they can have cervical fractures, so really tricky. But again, like it's ABC first, and unfortunately, they're just more at risk of having those morbidity afterwards. Great question. Yeah.
You have to accept that and that risk, to manage the priorities, right?
Yes, exactly. Yes.
It's really important to have those signs so that there is full awareness all the time that this is a child that we need to handle more carefully, but you still need to do what you need to do.
Yes, exactly. Yes, the sign, yeah, especially in settings that are not emergent, because often, especially with rotating, right, nursing is difficult. They don't always know the patient, so we really have those huge signs at the bedside, right, that indicates handle me with care, and then we have those more specific recommendation around handling. Those are really, really important. I find they make a huge difference.
Okay. And I don't see any other questions, but I have one further question for you. I hadn't appreciated how bisphosphonates were such a potent analgesic. You mentioned that when you used it in the child that, in that first week of life. Can you explain what the mechanism, like how is it such a good analgesic in those contexts?
Yeah, that's the $1 million question. We still don't have a good mechanism on why it works so well, but it does. It's like a Tylenol for the bones. So it really is an analgesic that's specific to bones. And typically the analgesic effect usually takes about 2 weeks sometimes to kick in. So it's not like it's not like morphine where you give it and you have the effect. And the nice thing is it lasts for months. So this analgesic effect, once it's given, it can be lasting for weeks and months. And we use it actually even so that was an example in the infant, but in patient like that second case, the girl that survived, she's on bisphosphonates more frequently than she would need from a bone fragility standpoint, and that's to keep her pain in check. So she's getting it every 3 months so that she's pain-free. So it's a kind of a long-term bone analgesic, and we use it in other conditions like CRPS, CRMO, and that's where the pain, or even avascular necrosis, and that's where the pain effect also happens to also increase bone density, but we use them sometimes for just their pain effect as well.
Interesting. Okay, learning a lot. So there's one more question in the chat, and that's whether the neck bones are affected as well. So
Yeah, so typically fractures do not, like it's rare to have a cervical fracture. So usually the fractures are lower down because of the change in the mechanical axis and the gravity. But the complication that we fear the most, yes, you can have a cervical fracture, but it's basilar invagination that often happens in the most severe cases of OI. And that's because the weight of the skull is more than what the bones are capable to endure, if you will. And you have this invagination, and there's unfortunately a few patients there's one that have passed away recently of this condition in adulthood. So that's the unfortunate piece, but we see that, yeah. So cervical spine can be affected. There's certain types of OI, like OI type 5, that have a predilection for cervical spine, like they have a worse phenotype of the cervical spine. So certain gene mutation will affect that even more than some other type of OI.
Okay, great. That's wonderful. So thank you, Marie-Ève. It's clear you've accomplished so much in your short time with us already. And I really look forward to where you're going to go from here. Thank you so much for sharing your expertise with us this morning and giving us this great grand rounds. Thank you very much.
Thanks for listening.
Okay, have a wonderful day, everyone.